Good morning. Thanks for the kind invitation to come and speak today. Okay, so I've been asked to talk to you about surgical wounds healing by secondary intention. I think we're all familiar with the definition. A surgical wound healing by secondary intention is an open wound resulting from a surgical procedure which is left to heal from the bottom up via the formation of granulation tissue. And this definition includes wounds which have been left open following surgery, either because the wound's infected or contaminated, there's insufficient tissue to close the wound primarily, or there's an underlying cavity in an abscess or a sinus. The definition also includes wounds which have dehisced after primary closure. So these are wounds which have been primarily closed and then for one reason or another, tension, infection, the wounds have fallen apart. They also include wounds which have resulted from sharp debridement of ulcers or necrotic tissue. What do we know about these type of wounds? Well, what we know is that they're pretty common. There are up to 6 million surgical procedures performed in the UK every year, and it's estimated that approximately 25% of these operations may result in a surgical wound healing by secondary intention. So pretty common. If you get a surgical wound healing by secondary intention, you stay in hospital longer. You occupy more hospital bed days, and you are more demanding on nursing care time. You more frequently require an additional surgical intervention. You're at higher risk of a superimposed infection. And we also know that there's a huge variety of different treatments out there for use in these type of wounds, which generally indicates we don't know which is the best treatment. And because these wounds take a long time to heal and require ongoing care in secondary and primary care, we know that these wounds cost a hell of a lot of money. What we don't know an awful lot, actually. We actually don't know the accurate prevalence. We don't know how common these wounds are. We don't know specific risk factors related to the patients. We don't know which patients are going to develop these wounds. We don't know risk factors related to surgery. We don't know whether subspecialties of surgery are more at risk than other subspecialties. We don't know whether emergency surgery is more at risk of developing a surgical wound healing by secondary intention than elective surgery. And we don't know whether surgeries that are more contaminated are more at risk of developing a surgical wound healing by secondary intention than non-contaminated surgery. We actually don't know the relative prevalence of etiology, whether wounds that are left open are much more common than wounds that have fallen apart. We don't know where these patients are managed primarily. We don't know whether that's mainly in primary or secondary care. And what we certainly don't know is which treatments promote healing and which treatments are cost effective. We don't know how frequently patients get superimposed infection, and we don't know whether these wounds contribute to patient mortality. And there's virtually no evidence on how these wounds affect patients' quality of life. So there's an awful lot we don't know. So almost 5 years ago now, this resulted in an application to the NHR for a programme grant for applied research. And what we applied for was a grant that would answer some of these unknowns, that would look at some of these questions and hope to provide some answers. So the title of our programme grant application was Characterising and Quantifying the Problem and Identifying Effective Treatments. And the first thing we did was we went round the country and got various experts in wound care, in health economic analysis, in clinical trials, in statistics. We got input from the NHS, we've got NHS management, input from a huge amount of input from nurses, and so we put this team together and we were successful. And the programme of research had four main work streams. The first work stream was a cross-sectional survey, and this aimed to characterise patient surgery and their wounds. The second work stream was a cohort study, which aimed to look at the clinical and cost-effectiveness of different treatments. The third work stream was a qualitative study looking at the impact of these wounds on patients' quality of life. And then the final work stream was a feasibility pilot study to assess whether a randomised controlled trial of different treatments for these wounds was possible. So if we look at the first work stream, this cross-sectional survey, we aim to improve our knowledge regarding the prevalence of these wounds. We aim to improve our knowledge regarding patient surgery and wound characteristics, and we aim to improve our knowledge regarding wound management details. We performed a cross-sectional survey in Hull and East Yorkshire, and over a 2-week period, we collected data from both the hospital environment, secondary care, and primary care. And we used a specific data collection form, which had been piloted, and the data collection form was completed on each eligible patient with a surgical wound healing by secondary intention, and the data collection form was completed by the person who was caring for that patient. So whether that was a clinic nurse, a district nurse, they completed the form and returned that form back to the York Clinical Trials Unit. And the form contained 18 questions which collected information on routine data. And over that 2-week period, we collected 187 forms which were returned. So this gave us a prevalence of 0.41 per thousand of the population, or 1 per 2,500 of the population. So these are really quite common wounds. And if you imagine 1 in 2,500 patients has one of these wounds, that means it's really quite common. We found that they were slightly more common in men. 62% of the patients whose data was returned were men, and the average age was 58 years. We also found that these wounds were associated with specific surgical subspecialties. By far the most common was colorectal surgery, with plastics and vascular surgery being the second most common. So if you're looking for patients with these wounds, it would make sense to focus on these surgical subspecialties. We also found that approximately equal numbers had been planned, i.e. when the patient went to theatre, it was always planned that they would leave the operating theatre with a wound that was open. And the other half of the patients were patients who'd had their wounds primarily closed and they fell apart. So equal numbers of planned and dehisced wounds. We collected some details about wound management, and the average duration of wounds in this survey was a month. So patients had had these wounds for a month. Infection was common, with about a third of patients being on antibiotics for their wound. Care in these patients was most commonly provided in the community, with 58% of patients being cared for in the community. About a third of patients were being cared for in hospital, either on the wards or in outpatients clinic, and only 5% were being cared for in their GP practices. Interestingly, 93% of patients were being managed with dressings. By far the most common dressing was a hydrocolloid dressing, with only 6% of patients had had negative pressure wound therapy. So a fairly low number. So that was the first work stream. We then went on to do the second work stream, which was a prospective observational cohort. And what we aimed to do was further characterise, get some more detail about the patients, get some more detail about the surgery and the wounds. And specifically, this cohort aimed to assess the clinical and cost effectiveness of intervention, the clinical and cost effectiveness of each treatment for these wounds. And we recruited patients with a surgical wound healing by secondary intention that was less than 3 weeks old. We collected baseline data. All patients were followed up for a minimum of 12 months, and at least 50% were followed up for longer than that. And what we monitored was events related to the wound. Specifically, we were interested in healing, and we were interested in treatment changes. We also collected data regarding complications. We were interested in infection rates. We're interested in readmission to hospital. We're interested in reoperations, and we're interested in mortality, how many patients died. So we recruited nearly 400 patients to this study. This is the largest study ever with patients with surgical wound healing by secondary intention. Again, a slight predominance of men. Again, the average age was about 50, 55. There was a significant incidence of comorbidities. Approximately 2/3 of patients were overweight or obese. Comorbidities were common. The most common comorbidity was cardiovascular disease, 38%, and diabetes was also really prevalent with 1/4 of patients. There was a high incidence of current smokers, and interestingly, 1/4 of patients had previously had a surgical wound healing by secondary intention. Two-thirds of patients had a planned surgical wound healing by secondary intention, so they had gone to theatre expecting to come out of theatre with a wound which had been left open. Nearly 2/3 of patients had undergone emergency surgery, so they had been admitted acutely, and they'd gone onto an emergency list or a CPOD list. Common locations, abdominal wounds made up 1/3 of cases, usually colorectal surgery. Leg and foot wounds also made up about 1/3 of cases, mainly vascular surgery cases. These were big wounds. The average area was 32 centimetres squared, so not insignificant wounds. And again, the common surgical specialties were colorectal surgery and vascular surgery. And many wounds, up to 20%, were infected at baseline. We also found that negative pressure therapy was becoming increasingly used in practice. If you remember from the survey, only 6% of patients had negative pressure wound therapy. In this study, negative pressure wound therapy was being used a lot more commonly. In nearly 30% of patients, negative pressure was being used. And for a long time, almost 3 weeks, patients were on negative pressure wound therapy. The good news is that the majority of these wounds healed. 82% of wounds in this study healed. The bad news is they take a long, long time to heal. The average was 86 days. 3 months with one of these wounds, nightmare. An infective episode during the study was common, 1/3 of patients. 17% of patients required a return to theatre, another operation. And not an insignificant number of patients, 7.4%, died in follow-up. So a significant problem. There's a significant incidence of infection. There's a significant incidence of requiring a reoperation, and a significant incidence of patients dying with these wounds. The good news is that overall, patients' quality of life improved. We used the short form 12, which measures a mental component score and a physical component score, and there was a significant improvement over time in these patients' quality of life as their wounds healed. We were interested in the factors which delayed time to healing, which resulted in you having a surgical wound healing by secondary intention longer than average. And when we looked at univariate analysis, the things that were associated with delayed time to healing were some of the things we might have expected, things like diabetes, cardiovascular disease. Interestingly, we found that men take a longer time to heal than women. We found that the level of surgical contamination at the time of surgery was associated with delayed time to healing. The more contaminated your wound at presentation at surgery, the longer the wound takes to heal. Unsurprisingly, bigger wounds take longer time to heal than smaller wounds. But importantly, infection at any time point delays wound healing. So it's important to make sure that we do everything we can to make sure these wounds don't get infected. When we did a multivariate analysis, accounting for the confounding variables, we found the things that remained significant with delay in time to healing were infection. So again, it emphasises the importance of keeping these wounds non-infected. Big wounds take longer to heal than small wounds, and if the original surgery was contaminated or dirty surgery, those wounds take longer to heal. One of the main interests that we were interested in looking at were the effects of negative pressure wound therapy on healing, because as I've already alluded to, the use of negative pressure wound therapy was becoming much more common. And when we looked at the unadjusted data, we found that patients who'd had negative pressure wound therapy were associated with a delayed time to healing. The median time to healing in patients who had negative pressure wound therapy was 175 days. Those who didn't have negative pressure wound therapy, it was 63 days. But you could argue that negative pressure wound therapy was used on big wounds, infected wounds, problematic wounds. But when we adjusted for that and modelled the data, this still held true. Negative pressure wound therapy was associated with a delay in time to healing. When we looked at the adjusted data, there was almost an extra 100 days that it was associated with delayed time to healing. And because of that, and because having a surgical wound healing by secondary intention negatively affects your quality of life and is more costly, we found that negative pressure wound therapy was not a cost-effective treatment for these wounds. But this is cohort data. This is not a randomised controlled trial. The third work stream was a qualitative study. The impact of these wounds on patients' quality of life, day-to-day living, there's no data on that. And what we aimed to do was to explore patients' views and experiences of living with an open surgical wound, a wound healing by secondary intention. So what we did was we performed in-depth, semi-structured interviews with individual patients. We used a standard topic guide which directed the interview, and the topic guide was developed with our patient representatives. They gave us areas which they thought were important to ask these patients about. The interviews were conducted in the patient's own home and lasted about an hour, and they were audio taped, so there was a tape recording of the interview which was fully transcribed, and then we used a modified framework approach, which is well recognised way to analyse this data in qualitative studies. So we interviewed 20 patients, 50-50 men and women, of the same age as our previous two study groups, with a median age of mid-50s. We tried to make sure we had a representation of colorectal, vascular and other patients. So 11 patients who'd undergone GI surgery, 5 patients who'd undergone vascular surgery. And the average duration of the wound in these patients was five months. And there were several emerging themes. There were 5 emerging themes that came out of this. One of these emerging themes was initial reaction. And patients often described alarm, shock, disbelief. And this was an initial reaction which was really common in patients who weren't expecting their surgical wound healing by secondary intention. So in patients who were going to theatre and you knew they were coming out of theatre with a surgical wound healing by secondary intention, you have to tell them. And then they know what to expect. If you're doing emergency colorectal surgery in a contaminated field, there's also a high risk that that wound might fall apart and the patient will end up with a surgical wound healing by secondary intention. And if you warn them that that might happen, this initial reaction of alarm, shock and disbelief is lessened. So there's a lesson for us surgeons here to communicate with our patients and warn them that a surgical wound healing by secondary intention is a certainty or a high probability in certain situations. Another emerging theme was wound-related symptoms, and some of these you might expect, things like pain, wound leakage, but a lot of the symptoms we didn't expect, systemic symptoms like reduced appetite, weight loss, weakness, muscle wastage, interrupted sleep, lack of energy. They were all really, really, really common, and we didn't predict that. The third emerging theme was wound healing expectations. Patients had a fear and anxiety that their wound would never heal, and they were often disappointed and frustrated at the slow rate of wound healing. And you can empathise with that. If you had a wound that, on average took 3 months to heal, you'd be enormously frustrated with that. There was also, patients were also desperate to get their wound healed. And they were desperate to return to normal activity and a return to a normal life. And they were desperate to try anything that would promote wound healing, that would accelerate wound healing, even if there was no evidence that that product worked. And often they were happy to take a treatment if it was painful or unpleasant. So there was this desperation for wound healing. They also viewed infection as a constant, insidious threat, and they recognised that infection had a negative impact on wound healing time. The fourth emerging theme was the impact on patients' psychological status and their social status. They found that their wound resulted in social isolation. They were confined to their home and they were unable to engage with the wider world. And that had an effect of making them lonely, bored, disconnected and depressed. Because these wounds often meant that patients couldn't go to work, there were significant financial implications, and this often put stress on interpersonal relationships. And the final emerging theme was how patients viewed their service provision, patients' opinions on their surgical care and their nursing care. And what patients valued is, during the hospital admission, they valued being listened to. They valued information. They valued communication. And this is another important message for us surgeons and people who are providing care for these patients. We need to take more time. We need to communicate deeper and longer. Patients also valued their wounds being reviewed, and they especially valued their wounds being reviewed by their surgeon, the surgeon who'd done their operation. They valued frequent dressing changes, and the other thing they highlighted was the lack of information at the time of discharge. And they thought it was really important that they had information about who was doing the dressing, who was going to take charge of the dressing, who was going to look after the wound, where they would go if there was a problem with the wound. And there's a gap in the care in that area. Regarding community care, what patients valued is they valued nursing continuity. They valued the same nurse coming at the same time each day. What they didn't like was variation in time and variation in nursing care, because they often got mixed messages. One nurse would say it looks good, the next nurse would say I'm not happy with that. And they valued that non-conflicting information, which was more consistent with the continuation of care, with the same people providing the care. So that qualitative study provided a huge insight into how these patients felt and the impact it had on these patients' lifestyles. The final emerging theme was how patients felt about negative pressure wound therapy. And if you believe the sales representative, these treatments, negative pressure wound therapy, is painless, allows patients to mobilise. Not true. Not true. What patients described, the positive aspects of negative pressure wound therapy, was that there was a reduced frequency of dressing changes, so dressings were changed every 2 or 3 days rather than 2 or 3 times a day. That was positive. They valued that. And because there was a reduced frequency of dressing changes, they perceived that the risk of infection with negative pressure was less. However, it wasn't all rosy. There were negative aspects of negative pressure wound therapy. The major one was pain. Patients actually find these wound changes really uncomfortable and really painful. So maybe there's some work to be done about how we can reduce the pain, putting local anaesthetic into the negative pressure before we take it off. They also described gaps in district nurse experience and expertise. Quite often they described that they were advising the nurse on what to do with the negative pressure. They also found it cumbersome. It's difficult to carry about. They tripped up over the wires. They tripped up over the tubes. They felt embarrassed having wounds and dressings that emerge out of the clothing and make a noise was embarrassing. They didn't like to go out in public. So even though you might be more mobile, you don't like to go on public transport because of the noisy dressing. It limited their mobility because of that and resulted in confinement to the home. So it's not all positive with negative pressure, and there are significant negatives there. And these negatives can be fixed. We just need to fix them. And the final work stream we went on to do was a feasibility study, and this started about 5 months ago, and we're about halfway through it. And what we aim to do with the feasibility study is to do a mini randomised controlled trial, not to find out whether negative pressure is better than usual care, but to find out whether a randomised controlled trial of negative pressure versus usual care is possible in these patients. So what we're interested in is, can we recruit these patients? What's our recruitment rate like? And if our recruitment rate is low, what are the reasons for non-recruitment? We want to look at our eligibility criteria. Does that preclude patients from going into this trial? Does the way in which we propose to collect data, does that work? Is there a better way of collecting the data? Can we supply, if we're randomising patients to negative pressure, can we supply that negative pressure in a timely fashion? Because obviously if they're randomised to negative pressure and then it takes you a week to get the negative pressure supplied and on the wound, that's a problem. Are our outcome measures suitable? In the feasibility study, we're going to follow patients up for 3 months, because that was our median time to healing was 86 days. Is that adequate? Do we need to follow these patients up for longer than that? How many patients withdraw, and why do they withdraw from the trial? Do patients complete the questionnaires? So we're in the cohort study, we sent quality of life questionnaires through the post, and the return rate was 60-70%, depending where you looked at the time point. Is there a way we can improve that questionnaire completion rate? Is the trial documentation that we propose to use fit for purpose? And given the feedback from patients about them advising community nurses on the application of negative pressure wound therapy, do we have to set in place a training regarding negative pressure wound therapy? So we're setting up a mini randomised controlled trial, not to answer the question which is best. We're setting up a mini randomised controlled trial to see whether we could do a randomised controlled trial and to correct any problems before we actually set off on a randomised controlled trial. So we aim to recruit for 7 months. We're about halfway through our recruitment period. We will then follow patients up for 3 months. We aim to assess them every 1 to 2 weeks. And how we're assessing them is our research nurses are going out and assessing the patients. And if you remember from the cohort study, that's different. In the cohort study, we were getting data from people who were actually looking after, caring for the patients who on a day-to-day basis. So that's one of the feasibility problems we've found. We've found that it's really intensive for our research nurses, and it may not be the best way of doing it, and that's the reason for doing a feasibility study. Healing assessment, we're actually using 2 ways. We're doing photographs and we're doing wound grids. We're looking at the pros and cons of both. We're collecting data on treatment changes and adverse events. So patients are having weekly or fortnightly reviews by our research nurses. We're also sending out questionnaires from the York Trials Unit. The questionnaires are sent out at baseline in 1 and 3 months. And they're questionnaires which are well-validated, generic quality of life questionnaires. And this is going on in 3 trusts. These are our inclusion criteria, pretty broad. Patients are randomised in a 1-to-1 ratio by the York Trials Unit, and this is by telephone. And the telephone randomisation is only available Monday to Friday, 9 till 5, and we found that that's not acceptable. Probably an online randomisation that's available 24/7 is the way to go. And they're randomised to one of 2 treatments, usual care, and the dressing used in usual care will be decided by the clinical team on negative pressure wound therapy, and we're using whatever the trusts involved normally use. The duration of negative pressure wound care is decided by the clinical team. We've only just got all 3 sites recruited. We've screened 93 patients, and 1 in 5 have been randomised. The most common reason for non-randomisation is that patients have already got negative pressure wound therapy. The surgeons who are managing these patients seem to be voting with their feet and putting negative pressure wound therapy on before our research nurses can get to them. And that may be modifiable with conversations with those surgeons. Another big reason was that these are tertiary referral centres and patients often live outside the area. And again, that is a problem that can be solved by using the people who provide their routine care to provide the data that we're interested in. Interestingly, only a small number of patients aren't suitable because their wound isn't suitable, and only a small number of patients aren't suitable because you can't get a seal with a vacuum. Response rates to questionnaires are reasonable. It's a bit early to say. And there's been a small number of serious adverse events. One patient had uncontrolled diabetes and 1 patient had a proximal amputation. Recruitment's ongoing, and our report to the NHR is due early next year. So in summary, these wounds are common. They're associated with specific surgical subspecialties. Equal numbers of planned and dehisced wounds, more frequently managed in the community. They take a hell of a long time to heal, up to 3 months. And the use of negative pressure wound therapy is increasing despite the paucity of evidence. We know that things that prolong wound healing time are infection, wound size, initial level of contamination, and, importantly, negative pressure wound therapy. We found that negative pressure wound therapy in this study was not cost effective. We found that surgical wounds have a profound impact on patients' quality of life. And we feel that with the knowledge that we've gained, a randomised controlled trial of negative pressure wound therapy for these wounds versus usual care is feasible. Thanks.